We have a very interesting topic on very interesting and very important topic of the ICU, that is cardioversion and defibrillation. So that will be taken by the consultant, Dr. Chandan Biswas and Amri Salt Lake. Oh, sorry, Amri Bhakuria. Hello.
Okay, hello.
Yes,
So
Chandan.
we can discuss about cardioversion and defibrillation. Now, you must have seen this device in your ICU, right? Or your ward, wherever you're going. So, what is this machine called? This is basically what you know is a defibrillator, right? So, the main function. So, what is a defibrillator? This defibrillator is a machine that provides an electrical charge that stops your heart's abnormal rhythm so that your heart can get back to the normal rhythm. That's what the basic function is all about. You see, the defibrillator actually stores the electric current and it gives the output as a direct current. It stores the current in a capacitor, and when you are pressing the buttons, the shock will be delivered so that the irritable cardiac tissue sustains its normal cardiac function. That's what the basic working principle of a defibrillator is. Apart from that, we have another particular device. This is known as, you must have also seen this in the hospitals, this is known as the automated external defibrillator. Now, this has a little better advantage, especially when you are providing out of the hospital care, because it is completely automated, so you need not think about it. It will automatically analyze the patient's rhythm and provide the electrical shock whenever it is required for the patients. So you must have gone through the variable terms like the shockable rhythm and the non-shockable rhythm, and these are all components of the advanced cardiac and life support ACLS. So if you have gone through these kind of trainings, you must have known like what the shockable and the non-shockable rhythms are. Let us revise those things. So what are the shockable rhythms? You see this wave you can see one of the shockable rhythm is a ventricular fibrillation. This typically where what happens, you have an undulating wave with a wide QRS complex. So these kind of waves are known as ventricular fibrillation. So this is one of the scenario where you can shock. This is a ventricular tachycardia. Here also, this is a monomorphic ventricular tachycardia where you are having very broad complex ECG findings. Apart from that, they do not have any other clear morphology. Here also, once again, you can shock the patient. This kind of rhythm in which looks almost normal, but if you see very carefully, you do not find a P wave. These are all supraventricular tachycardias, and these are also these patients usually present with a very fast rate. But supraventricular tachycardia, if you have a pulseless supraventricular tachycardia, and if the patient is hemodynamically compromised, then definitely you have to think about cardioversion, right? Apart from that, you have the polymorphic VT, also known as the torsades. Here you can see the undulating, the sine wave-like pattern of the ECG. So these kind of waves, if you find in the patient, you are supposed to shock the patient, right? Apart from there are certain rhythms like that of atrial fibrillation, and we have the atrial flutter. Now, in these particular cases, if the patient is not maintaining hemodynamic stable condition, then you will have to consider about shocking the patient. In atrial fibrillation, what you see here also, you do not find the P waves. These are irregular pulses, and the kind of waves is shown in the upper ECG. Atrial flutter, they will have a very sawtooth-like pattern. Here again, you have to consider about shocking the patient, provided the patient is not hemodynamically stable. Now, if we come to the non-shockable rhythms, you see the non-shockable rhythms are those like the first one. These are all pulseless electrical activity. Now, these cases, what happens is your heart, the cardiac muscle is actually irritable and it shows some kind of undulating waves, but however, there is no, but the heart is not actually contracting. So basically, you're not getting a pulse. However, the electrical activity is there. So in the curve A, the curve B is another form of PA where you can see some kind of depolarization going on, but the heart is unable to pump. In the curve C also here, some kind of activity is seen, but ultimately there is no pulse. So these are all pulseless electrical activities. These are non-shockable rhythms, and here you're supposed to give only the CPR to the patient. And what about this? This is the asystole. The initial parts ECG shows kind of a normal-like rhythm, and then what happens later on, or a PA it could be, and then later on you see that there is no activity at all. So this kind of activity, this kind of ECG is known as a pulseless electrical activity, right? So as we know about the various types of shockable and the non-shockable rhythm, we'll now see what is defibrillation versus what is cardioversion. See, defibrillation is the asynchronous delivery of a high energy shock compared to that of a cardioversion. Now, in cardioversion, what you do is you involve a synchronizing energy is provided to the QRS complex. So basically, you have to attach the ECG leads to the patient, and the machine will detect the QRS and it will provide the shock synchronizing with the QRS complex. Now, a defibrillation shock from an AD uses a more powerful energy and resets the heart to the normal condition. So more joules are used in case of defibrillation, whereas in case of cardioversion, we use a lower amount of energy. A cardioversion is synchronized, whereas a defibrillation cannot be synchronized. Now, rhythms for synchronized cardioversion, if you see the supraventricular tachycardia, ventricular tachycardia, if they are pulseless, then you have to go for this synchronized cardioversion apart from the atrial flutter and the atrial fibrillation. So these are the particular waves that you should be considering. Now, if you see the controls of this particular device very carefully, there are various knobs. You see the first dial, which is showing on the top right, the green dial, it is showing the amount of energy that you can provide to the patient. And the numbers are denoted in form of joules. Next, you have the charge button and the shock button. Charge is for when you press the charge button, this machine stores the electric energy. And when you press the shock button, then it provides the electrical current to the patient. And here the monitor is there. The monitor will show you the heart rate provided if you have connected it to the ECG leads. Apart from that, it also shows certain other capacities like the charge delivered, and it shows the action potentials. So what happens in case of a synchronized cardioversion? You see the initial part of the ECG showing the abnormal waves. Now there are certain pointers which are given on the screen, and the pointers denotes other R waves. So this is synchronized. So whenever you press the sync button, you see there is a sync button on the screen as well. So whenever you're pressing the sync button, after attaching the ECG leads, it will analyze the rhythm and it will detect the R waves. So the machine will deliver the shock whenever it synchronizes with the R waves. Otherwise, the machine will not be able to deliver the shock. So what happens if you don't synchronize these kind of synchronize in such kind of arrhythmias? So here also, if you don't synchronize, then what happens? You are providing the current in the if it provides the current on the T wave, what happens is that the heart actually gets confused and you get the R on T phenomenon, where you can have this torsades you can actually worsen the patient by giving the patient a torsades. So in such cases, you have to avoid any asynchronous and you have to synchronize with the R wave. So that is why the synchronous cardioversion is actually necessary. Now, how do you place your paddles? Now, these paddles are actually provided. One is a positive, another negative, and this has to be firmly attached to the patient's chest wall. Now, if you see, if you are having an adult patient for whom we are resuscitating, you're supposed to place the one on the one is the sternal paddle, which is at the top, and the other is the apical paddle. Now, for adult patients, these are usually attached in such figures. In male patients like this, and then the female patients just below the breast. You see, this is how you place it. Now, if the patient already has pacemaker in place, then you have to use the paddles in such a way so that it is away from the circuit of the pacemaker. Otherwise, it can damage the pacemaker which has already been inserted. In case of children, however, the placement is a little different. In such cases, you have to place one paddle in the front and one paddle at the back. So that is how you place it. Apart from that, you also have to note, in case of adults, the paddle size is much larger, but in case of pediatric patients, the paddle size is much smaller. So you have to choose the designated paddle size for delivering the shock. Now, how do you go for the synchronized cardioversion? You see, in synchronized cardioversion, the energy of shock for defibrillation is different and is much lower. So for defibrillation, if you are using a biphasic machine, the manufacturer recommendation, you actually have to go to the manual if it's there. So the initial usual dose recommended by the American Heart Association is 120, and you go on increasing the shock, and you can go to a maximum of 200 joules. If it is unknown, then use the maximum available current which is available. The second, that is, you start on with a lower joule and you gradually as you proceed in parts of the CPR cycle, you go for higher energy shocks. Now, second is that subsequent doses should be equivalent. Higher doses may be considered. Now, this is for the biphasic machine. Now, see the defibrillator or there are also two varieties. One is a monophasic and a biphasic. Now, biphasic is the one which is usually preferred. There a lower energy of shock can be used to provide a better performance. However, the mono, if you're having an older machine, then you might be having a monophasic machine. In those cases, you have to use a higher energy of 360 joules. That is how this works. Now, in case of defibrillation for children, you don't use so much of energy. The usual dictum is for the first shock, use 2 joule per kg. For the second shock, use 4 joule per kg. If subsequent shocks are required, then 2 to 4 joules. This is not 24. This will be 2 to 4 joules per kg, but maximum of 10 joules per kg can be delivered. If the subject is of a higher body weight, then you can also go as high as the adult dose, depending upon the weight of the child. Now, for synchronized cardioversion, in case of pediatric population, you begin with 0.5 to 1 joule per kg. If it's not effective, you go on increasing it to 2 joule per kg. If required, the patient might also need some sedation, because this is not a very comfortable experience for the patient. But whatever be it, do not delay the cardioversion, because otherwise you might be losing the patient. So after you've attached the paddles, this is actually showing depicting the AED, but here also, if you are using the standard defibrillation or the cardioversion, one thing that is very important is that only the provider of the shock will be holding the paddles. The other people who are there, they should be away from the patient. So whenever you have the patient in your hand, you first of all apply the jelly so that the conductance is good on the paddles. You apply it according to the placement which we have already shown, and then you have to say that I am clear, you clear, all clear. Then what happens? Everybody should be away from the patient, and then you deliver the shock. If you by accident, if you're touching the patient, you yourself might get shock and you might get an injury from that. So that is definitely not recommended. So that is how you're supposed to do. This picture actually clearly demonstrates how you're supposed to deal with such kind of shocks. Now, as we proceed, as you will get trained into more topics like the ACLS and the BLS, you see this is how the rhythm of this is how the cycle of the CPR goes on. So every time in CPR, you check the rhythm. If you see if it's a shockable rhythm like a ventricular fibrillation or a ventricular tachycardia, you deliver the shock, you continue the CPR, you monitor for the quality, and this is done by the team leader, and then you go on. This goes on actually in cycles. Apart from that, you have to get the IV access, advanced airway, and treatment of the reversible causes. This is how the entire process should look like, right? So that is what the basics of our defibrillation and cardioversion is. This is how it goes, right? Now, if you are interested, we'll go further and we'll just go for certain trivia. Now, you're all free to unmute yourself if you feel free to answer. So what is the type of current that is used in a defibrillator? Indirect, direct, alternating, or sinusoidal? So what is your answer? Anybody? Nobody's answering. So what is the type of current used? You use a direct current, right? Now let us go to the next question. Now, how do you place your defibrillator paddles in an adult? One is left and right, top down, apex sternum, or thorax abdomen? The answer here will be apex and sternum, right? Now let us see about synchronized cardioversion is used in option A, atrial fibrillation with hemodynamic instability, atrial fibrillation with heart rate of 140 and BP 120/70, C, ventricular fibrillation with a low blood pressure, or a sinus tachycardia with heart rate 130 beats per minute with BP 90/60. So what is the answer? Here the answer will be atrial fibrillation with hemodynamic instability. Because in ventricular fibrillation, you have to go for the defibrillator, right? Now, what is the type of energy that is used in defibrillation in an adult? It is 120 joule monophasic or 500 joule monophasic, 120 joule biphasic, or a 360 joule biphasic. Here the answer will be 120 joule biphasic, right? Now then, synchronized cardioversion, the shock is delivered in which phase? P, R, T or PR interval? And the answer shall be R, at the R rate, right? Now, what are the shockable rhythms? What is it, a PA? Is it an atrial fibrillation with BP of 110/60, a ventricular fibrillation, or a bifascicular block? The answer shall be a ventricular fibrillation, VF, right? So that was a very short presentation from my end. Now, if you have any questions, you can definitely go forward. Nisha, hello.
Yes, sir.
So any questions from the audience? I don't see any questions. So can we end it?
Wait for 2-3 minutes. If candidates have any question, then they will type in the chat box.
Sure. Now the maximum joule that is used in cardioversion, you always have to start with a lower energy. So it depends upon the manufacturer it want. In case of pediatric patients that I've already shown, like if we go to the slides once again, I'll just show you. Now, what is recommended is this is as per the ACLS guidelines. Like for adult patients, you usually start with a lower energy, right? You can start on with 120 joules for defibrillation or cardioversion for the adult patients. And you basically what you have to do is if it doesn't work with a lower energy, in certain cases also as low as 50 joule can be used, right? But the standard recommendation starts from 120 and you go as high as to 200 joules. This is for the adult patients. Now for the children, what you have for cardioversion, you start with a lower energy of 0.5 to 1 joule and gradually you go into increments to a maximum of 2 joule per kg. That is what the standard recommendation is all about, right? But whatever be it, you always have to go to the manufacturing, the machine's manual, because they usually recommend they have certain energy specifications, right? So that is something that you need to look into before you proceed for that. So in whatever setup you're working, whenever you have the machine in hand, you go to the manual and get accustomed to it. The paddles, the amount of energy that should be delivered, whether it's a monophasic one or a biphasic one, and you get along with the system. One thing which is different is in case of automated external defibrillator, you do not have any kind of energy specified as such, because the machine actually has two settings, whether it's a patient is an adult patient or whether the patient is a pediatric patient. Accordingly, it analyzes the patient and delivers a shock. So in AEDs, it's completely automated, but however, if you're having a manual defibrillator then you have to choose the amount of energy depending upon the machine type and also the patient's body weight, right? See, if it's not reverted to the normal rhythm, what you have to do is you have to continue delivering the shocks as I've shown you in the CPR cycles, right? For that reason, you have to go into the ACLS protocol, like the number of shocks that you can deliver. But what happens is that this does not continue indefinitely. Usually, after one or two shocks which are delivered to the patient, the rhythm actually changes. So, depending upon what kind of rhythm you're having, whether it's a pulseless electrical activity, then the shock won't be recommended. If it's an asystole, shock won't be recommended. But however, if it's a shockable rhythm, you have to go on as long as the patient is having some kind of electrical activity. So you have to analyze the rhythm and accordingly deliver. So there is no definite limit what is mentioned in the ACLS protocols, but usually that is you have to adhere to the ACLS cycles, and that is how you have to go on. So I think maximum how many shocks can be given, I think that is also answered in this particular question only. There's no definite mention or guideline which is mentioned in the ACLS protocols, but what you have to do is that you have to give on giving the shocks. uh, I'll show you the slide over here. You have to continue this cycle of CPR has to go on, right? And you deliver the shock only if it's a shockable rhythm until you continue the CPR. So this question will rather be answered in a way like how long will you continue? You will continue till you continue the CPR. Now, if you find that there is no return of the circulation either after say 20 minutes or 40 of the CPR, or then you have to decide. It's a clinician decision, like when you have to end the cause. If there are certain correctable causes, you correct it. If it is not, and yet the patient is not reverting to the normal rhythm, then you have to call it. But usually, what we recommend is standard at least of 20 to 20 minutes of CPR is usually recommended prior to declaring the patient. So in such a case, you have to continue the CPR and deliver the shock accordingly. Any other questions from your side?